Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Apria. A few years ago, the AHRQ report indicated that there was insufficient evidence to support treatment of obstructive sleep apnea with PAP therapy solely to improve cardiovascular disease and mortality. This led to a number of conversations within the sleep community about whether this was due to the quality of data we have been collecting, study design, which for ethical reasons cannot exclude sleepy people from receiving PAP therapy, or if there is some other reason why there isn't enough data to support using PAP therapy for obstructive sleep apnea in non-sleepy people. Dr. Sanja Jelic and Dr. Daniel Gottlieb have been studying the effect of positive airway pressure on inflammatory mediators in the lungs. They postulate that perhaps there is a pro-inflammatory effect of PAP therapy. This may explain why there isn't enough data to support the use of PAP therapy for non-sleepy obstructive sleep apnea. Dr. Jelic is a professor of medicine in the Division of Pulmonary, Allergy, and Critical Care Medicine at Columbia University. She is also director for the Center for Sleep Medicine at Columbia University. Dr. Gottlieb is an associate professor of medicine in the Division of Sleep and Circadian Disorders at the Brigham and Women's Hospital. Welcome. Thanks for joining us today.
Glad to be here.
Thank you for inviting me.
So help me understand this. The theory is that intermittent hypoxia increases the risk of cardiovascular disease, right? So shouldn't we expect that cardiovascular risk decreases with treatment?
Well, that certainly was the expectation. There's a lot of evidence from epidemiologic studies, from physiologic studies in both animals and humans, and from some experimental data that sleep apnea should be a cause of increased cardiovascular risk. And much of the reason for that probably has to do with the intermittent hypoxia that occurs in sleep apnea. And so it certainly was expected that with treatment of the sleep apnea, with removal of the hypoxia and any other consequences of sleep apnea, such as arousal, that risk of cardiovascular disease would decrease. And so I think that the entire community was surprised when several randomized clinical trials over the last decade showed no apparent reduction in cardiovascular risk with treatment. And there are a number of reasons why that might be, and we may discuss some of those. I think the findings that Dr. Jelic and I have had suggest a potential reason that hasn't been widely discussed.
Okay, so let's talk about that. You had a study that was published in The Lancet, I think. It was called CPAP May Promote an Endothelial Inflammatory Milieu in Sleep Apnea After Coronary Revascularization. So tell me about this.
So it was in a journal eBiomedicine, which is one of the Lancet Group's journal. And we actually, just like everybody else, thought that inflammatory biomarkers are elevated in obstructive sleep apnea, which we found. And we thought that maybe treatment with CPAP obviously would be expected to lower these inflammatory markers. However, we noticed the opposite trend. In fact, it was significant. We checked 2 additional cohorts and it held. So that really was the first sign that something may be amiss with this CPAP therapy, that maybe there is something happening, some kind of side effect of it completely unrecognized that may undermine expected positive effect of CPAP on cardiovascular risk. So we we called the investigator from the study called RICATSA, which was the first of these 3 large randomized trials of CPAP therapy in obstructive sleep apnea patients that was published in 2016. And we collaborated with them and analyzed some of the samples they had left over from the baseline after 12 months of therapy. And we found that indeed in this larger cohort with a randomized intervention of CPAP versus no CPAP, this unexpected trend in further increase in some of the inflammatory markers after CPAP therapy actually was observed again.
So tell me about some of these inflammatory mediators.
We independently from these trials, we were working on mechanisms how intermittent hypoxia, which is a feature of obstructive sleep apnea and thought to be a main contributor to increased cardiovascular risk, how does that activate endothelial cells and make them dysfunctional? And we found this biomarker called angiopoietin-2, which is released from all endothelial cells. And in patients with obstructive sleep apnea prior to treatment, the level of these biomarkers is higher compared to healthy controls. And then once these patients start using CPAP, instead of going down, this inflammatory biomarker increases further. So we checked that. And also some of other biomarkers which are known to work in conjunction with this angiopoietin-2 pathway. And they include vascular endothelial growth factor, or VEGF, well-known angiopoietic factor that is mainly secreted in response to hypoxia, which is again feature of sleep apnea. And we checked the receptor for angiopoietin, as well as some other known biomarkers to be elevated in patients with obstructive sleep apnea compared to healthy controls. So we looked at this set of biomarkers and found something interesting, that treatment with sleep apnea kind of favors, results in unfavorable trajectory of these biomarkers. In other words, the angiopoietin level stays at a higher level. It doesn't naturally go down as you would expect from the population that is enrolled in Ricasa, which I will get to in a minute. While this VEGF, after we removed hypoxia stimulus with CPAP, which is has always been known to result in a normoxia all night, then this VEGF went down. And this particular constellation of decreased vascular endothelial growth factor levels with persistently increased angiopoietin-2 in fact leads to vessel regression, which we know from animal models, as opposed to progression, which is what you would want and expect. Yes, I just want to make sure that everybody understands the population of this Ricasa trial. Those are the people who had actually acute cardiovascular event, generally something with coronary artery disease, within 6 months prior to enrollment. So in these patients after the acute event, and they had to undergo percutaneous intervention or surgical vascular intervention. And usually the levels of these biomarkers after acute cardiac injury are high. And we know from other studies not involving sleep apnea patients, the natural trajectory of these biomarkers. And it's known that angiopoietin gradually should decrease, while vascular endothelial growth factor continues to increase even after a year. And it's been shown to be associated with lower cardiovascular risk recently, as well as some of these polymorphism of the gene resulting in greater levels is also associated with better cardiovascular outcomes. So that's why this reduction in VEGF, which we noticed, and it had been noticed numerous times before in randomized and non-randomized studies of sleep apnea treatment with CPAP, which was considered generally great. This level of biomarkers is going down, but we think it's actually could be detrimental.
So if I understand you right, so this angiopoietin-2 levels were higher in patients who had obstructive sleep apnea compared to non-OSA patients. And then would they continue to get even higher with PAP therapy, or would they just not fall?
There are a couple of different studies. In the initial study that we published back in 2022 and in other publications from Sanja's lab, the angiopoietin levels are high, and they correlate with severity in people's sleep apnea compared to those without. And the levels correlate with the severity of sleep apnea. But in contrast to expectation, again, they went up rather than falling with CPAP therapy. Now, in the Ricasa trial, the angiopoietin levels were high to begin with because, as I said, these were patients who were enrolled on average about 3 months following the coronary revascularization procedure. They were high at baseline. The expectation was that without other therapy, they would fall over time. And in fact, in the participants who were treated with usual care, that is not with CPAP, the angiopoietin levels did in fact decline over the 12-month follow-up period. Whereas for the patients treated with CPAP, the angiopoietin levels that were high at baseline remained high. Conversely, the VEGF levels fell with CPAP treatment. And I think one important point, just to expand on what Sanja said, the effects of angiopoietin 2 are context dependent, and they can be either cause angiogenesis or vascular inflammation and vessel regression. And in the presence of high levels of VEGF, angiopoietin 2 tends to have angiogenic effects, and so presumably positive effects, whereas with low levels of VEGF, that will tend to favor the inflammatory effects of angiopoietin 2. So so with treatment with CPAP, this group of patients with sleep apnea following coronary revascularization went from compared to the usual care patients, had high levels of angiopoietin 2, low levels of VEGF-A, and that presumably, we think, is what may contribute to increased cardiovascular risk in the patients treated with CPAP.
Because we think VEGF is cardioprotective.
Right.
Okay.
And it interacts with angiopoietin 2 to push so that angiopoietin 2 in the presence of high levels of VEGF may be protective as well, but with low levels of VEGF may be detrimental.
So did this change depending on what the pressure setting was, or was it just PAP versus no PAP?
There was a correlation of angiopoietin levels with the CPAP pressure.
And the relationship was then the higher the pressure, the greater the amount of angiopoietin 2?
Correct, yeah.
And then also the VEGF was lower then?
I don't know that there was any correlation I can't recall if we even looked at the correlation of pressure with VEGF. But the expectation is that VEGF levels are being driven by degree of hypoxia rather than by pressure.
So then what does untreated sleep apnea alone do to these markers?
So untreated sleep apnea, because of the recurrent hypoxemia at night, promotes secretion of VEGF. So previous studies have shown that VEGF levels are greater in patients with sleep apnea than healthy controls. And also the treatment with CPAP lowers VEGF level. And that was traditionally considered beneficial effect, but in light of our findings, it may not be so.
Well, that's what I'm wondering, because it sounds like that's, it leads to sort of something that we don't want.
Exactly. And because angiopoietin, we were the first one to look at angiopoietin levels in sleep apnea. And it's interesting, again, as you correctly recognized and then reiterated, patients with untreated obstructive sleep apnea had greater levels than healthy controls. Okay? So then again, it went up with the CPAP treatment, which was unexpected. And it's the interesting thing is that this angiopoietin and VEGF are excreted from endothelium all over the body. But interestingly, lung as an organ contains about 25% to 1/3 of the human endothelium. So it's a very large source of these endothelial molecules, factors. So this is what gave us an idea. Could it be that this CPAP is functioning something like a mini ventilator-induced lung injury, because we are pushing air under pressure and increase lung volumes in patients. And that was, in a sleep community, never really thought of as anything detrimental. In fact, CPAP has very little side effects, most of them aerophagia and such, but not really anything systemic. So that's what gave us an idea to try to mechanistically link these findings with the effect of CPAP.
So that's really interesting that you say that, because it does kind of remind me of my ICU days where we tried to avoid higher vent pressure settings. So is this all sort of endothelial cell stretch to release angiopoietin-2, or is this sort of like barotrauma?
Well, I think it's, since we haven't looked at the lungs directly, I think it's speculative. But the pressure certainly with CPAP are not high relative to the pressures that someone on positive pressure ventilation in the ICU is likely to receive. But a typical, say 10 centimeters of CPAP pressure is associated with an increase in FRC of the lung of about 1 liter. And when you consider, so it means that we're starting our breath, probably already a 0.5 liter higher than what our lung volume is at end inspiration on a typical, tidal breathing. And so, the lungs are quite inflated. And even though it's not a very high pressure, it's pressure that is experienced pressure and, inflation that are experienced by the lung for many hours over, a long period of time. And so certainly it seems plausible that this could be associated with, with adverse consequences that may in some ways be similar to the effects of high pressure ventilation in the ICU, but it's probably not a perfect analogy.
So let's take a short break, and when we come back, we'll talk more about how PAP may cause pro-inflammatory mediator levels to rise when we treat obstructive sleep apnea with higher settings. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apria Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apria Healthcare. Discover more about our innovative sleep program online today at apria.com.
Welcome back to Talking Sleep. We're talking with Dr. Jelic and Dr. Gottlieb about their work on the pro-inflammatory effects of PAP therapy. So, Dan, when I was preparing for this, I came across an article you wrote a long time ago about the use of CPAP versus oxygen. And so then hearing all of this with, lung stretch and that sort of thing, should we be using supplemental oxygen to treat the intermittent hypoxia instead of PAP therapy?
Well, it's a good question. As you know, if you read that article from a decade ago, we were looking at CPAP compared to oxygen at night compared to usual care with the primary outcome of blood pressure. And what we saw was that CPAP reduced blood pressure by the now familiar 2 to 3 millimeters of mercury, while oxygen did not reduce blood pressure. However, there is another study from the Chris Turnbull and group at Oxford in which they did a 2-week CPAP withdrawal protocol in patients who were adherent to CPAP, and they provided one group with oxygen and the other with air rescue. And what they found was that in the group given supplemental oxygen, their blood pressure was about 6 millimeters of mercury lower than in the group that did not have oxygen rescue at night. So I think that but these are two really fairly small clinical studies, and I think that it's an important question, but studies specifically looking at this question are needed to answer whether oxygen has benefits. We know that it doesn't, for most patients, significantly reduce the apnea-hypopnea index or improve daytime symptoms, but since many people are being many people with sleep apnea are minimally symptomatic or asymptomatic, if oxygen were able to reduce cardiovascular risk, it would certainly be an important alternative therapy. We just don't have the information yet.
Well, because weren't we always taught that supplemental oxygen just makes the events longer?
Well, and that was shown 30 years ago, I guess. Yes, it does increase the duration of events, which should increase the carbon dioxide levels. So even if you control hypoxia, you may have some adverse effects related to hypercapnia, which will also increase blood pressure. But I think the specific, the balance of benefit versus harm from oxygen isn't clear. So I do think it's an area that's worth looking at. And in fact, currently we are going back to samples collected from that heartbeat study from, I think it was 2014. And we are in the process of looking at what happens to these inflammatory markers within the participants who are treated with oxygen to see whether, in fact, we see a beneficial change in those biomarkers.
So, Sanja, you mentioned the Ricazza trial. Were the patients similar? Did they include sleepy patients? I mean, who's excluded from that?
Yes, so there are two caveats that are common to all of these three large randomized trials, including Ricazza.
Okay.
One, that sleepy patients were excluded. There was a slight difference in the level based on Epworth Sleepiness Scale. Some trials excluded those with any sleepiness, in other words, Epworth more than 10. And the SAFE trial, which is from Australian and Asian population mostly, they excluded those with 15 or more, or maybe more than 15. I don't know exactly. So patients who are sleepy just cannot be, or at least that's a current thinking, cannot be ethically randomized to no CPAP. They can sign a consent to accept personal risk, but the society cannot accept societal risk.
Yeah.
So we will actually never know whether patients who have a moderate to severe daytime sleepiness as a consequence of sleep apnea actually benefit from these therapies. We just have to reconcile to this fact.
So one of the arguments, though, about the SAVE trial was that PAP usage was suboptimal.
Yes, PAP usage was so-called suboptimal in all of these trials. The average time is 3 to 4 hours at the end of the trial. So that is less than currently mandated by insurance, 4 hours on 70% of the nights. So the thing is that, well, post hoc analysis are always flawed, as Dan knows better than me. But post hoc analysis, nevertheless, can give us a little insight.
Yeah.
And in two large trials, this SAVE and the other one from Spain called ISAC, they are patients who use CPAP more than 4 hours on 70% of nights. Otherwise, in other words, those who fulfill the current U.S. insurance compliance criteria also did not have any improvement in cardiovascular risk compared to those who were randomized to no CPAPs. And in Ricazza trial, because it was smaller and even making it even less reliable, there was some signal that cardiovascular risk would be decreased somewhat with more adherence. I just want to point out that in our paper about these biomarkers, which we are discussing now, we found that the pressure levels on CPAP correlate directly with levels of angiopoietin 2, for instance, and in fact, levels of another biomarker indicating lung inflation correlated directly, positively, with cardiovascular outcomes. In other words, greater the pressure, the greater the cardiovascular risk. But interestingly, the number of hours used, which is a standard measure of adherence with CPAP therapy, did not correlate with any of these.
It didn't.
So, yeah, so what we think is that CPAP use should be covering the period at risk, and we should clinically continue to encourage use as long as possible, preferably during the entire sleep period. By that, maybe we should use slightly more conservative pressures. So it's not a question of hours of usage, it's the question of what level of pressure is being used.
So what is the right number?
So we have some numbers actually. So in Ricazzo trial, which was our population, the treatment was auto-PAP, auto-positive airway pressure. So we had their median pressure, which we used. And when we did a split of the sample based on median, which was 7, those with the pressures, median pressure greater than 7 had increased cardiovascular risk compared to those with a 7 or below. So we think that it's not really a magic number. Of course, it has to be confirmed in a larger trial, but something like around 7 or so should be maybe tested whether that would be sufficient to treat most of the obstructions. If not, just some incremental increase. I mean, I can tell you, I've been doing sleep medicine for years now, and just anecdotally, when we check a compliance report at 2 to 3 months follow-up, I would say vast majority of patients has a median pressure of 7 or 8. And this is even here in New York, where the representative U.S. population is. I just want to touch on what frequently we are asked whether body habitus requires, heavier patients requires higher pressure. Yes. Body mass index does correlate with required pressures, but the severity of sleep apnea does not. So even very severe sleep apnea can be treated with quite conservative pressures, and it needs to be checked on a compliance report whether it works, if the auto-PAP is used or with titration.
So so again, this is reminding me of my ICU days from 100 years ago, but it reminds me a little bit of like permissive hypercapnia. So should we maybe accept a higher residual AHI in order to keep the pressures lower?
I think that's one potential outcome of response to this finding. I think that we do need studies to explore that. I don't think that we have enough information from this to say that that's what we should do and what we should be doing and what a particular pressure should be. We are trying to look at this in a couple of larger clinical trials to see whether we get a clear indication of a particular pressure threshold that we should be trying to achieve. But there's a lot that remains unknown at this point.
2025 marks the 50th anniversary of the AASM. Here's Dr. Stuart Kwan telling us about the early stages of the JCSM.
The AASM decided that we needed a journal that would be devoted to the needs of the membership of the AASM, which is primarily clinicians, and that we would publish our practice parameter papers there. We would encourage people to publish clinical types of research. Basically, that's the way the journal started. So one of the problems in starting a new journal, of course, is that it was easy to tell the membership we had a new journal, but there was hesitancy to submit because the journal was not indexed. And that is the primary obstacle. You'd have to go around asking people to submit papers, realizing that, hey, you'll get indexed when it gets accepted to be in the index. And And you have to take it on faith that eventually will get indexed. And so it was always a little difficult to get people initially to submit papers. In the first issue, David White had a paper looking at how many sleep labs there were in the United States. And that was like one of the first papers that got in.
Now back to our conversation. So, is the idea that fixing the intermittent hypoxia and arousals are good, right? But the way we do that may have its own risks?
Yes. So I think that the model that we see is that obstructive sleep apnea through intermittent hypoxia and associated impacts on endothelial function and sympathetic nervous system activity, oxidative stress, and so forth, including increasing angiopoietin-2, will increase cardiovascular risk, and that treating sleep apnea should reduce that risk. On the other hand, CPAP through alveolar distension with increases in angiopoietin-2 coinciding with decreases in vascular endothelial growth factor may counterbalance the expected benefits of treating sleep apnea on cardiovascular risk. And I think in this regard, it's worth considering some work that we've done that was led by Dr. Ali Hazar-Barzin in this Ricadza cohort, because what he did was to look at measure of hypoxemia to risk stratify participants into high cardiovascular risk versus low cardiovascular risk groups. And when you look at the entire sample, you see no difference between the CPAP and the no CPAP groups. But in the group that was identified as being at high cardiovascular risk, actually in the paper I'm thinking of was based on the heart rate response to apnea events. Those who are identified as being at high cardiovascular risk appeared to benefit from CPAP therapy, while those who at baseline appeared to be at low cardiovascular risk seemed to have a worse cardiovascular outcome with treatment. And I think that fits very nicely with our, with the model that we've proposed, suggesting that because you might think that in those at high risk, the benefits of treating the intermittent hypoxemia or the sleep apnea are going to outweigh the adverse effects of CPAP, whereas in people at low baseline risk, it might be the opposite. So I think that one thing that's likely to be very important for our field over the next several years is to validate these markers that have been proposed of cardiovascular risk, allowing for for more individualized therapy, and it might identify a group that's likely to benefit and a group that's likely to be harmed that might well influence clinical decision making.
So what happens if you have someone with underlying lung disease, COPD or IPF or something like that? Are they at higher risk for PAP-related inflammation?
I don't think we know.
Because it really, I hear what you're saying about this risk stratification, right? And it makes me feel like we're kind of learning from our cardiology colleagues and how they do this, right? This is just part of their standard practice. And then, we will hopefully one day have the tools to be able to do that.
Yes, I think, I think sleep is a young field still.
Mm-hmm.
And I think that we are, I think the field has become increasingly aware of the limitations of our primary metric of disease severity.
Yeah.
And a lot of work is now going on in that area to try and identify other metrics that will help to risk stratify and that may help to identify appropriate treatments. And I expect that we'll see a lot more coming out of that over the next 5 to 10 years.
So, Dr. Jelic, you kind of mentioned that this was done via auto-titrating CPAP, right, for a lot of these trials. Do we see the same thing with BiPAP?
We don't know because we haven't really looked at any study with the bi-level. But I think here we are facing a question of most commonly used pressure. So in a bi-level, I guess during inspiration, we will have a higher pressure. So during that would accumulate overnight into certain number of minutes or hours spent on a higher pressure. So I do not know what way. I can only speculate that the higher if the pressures are high enough, we would probably see something similar.
I mean, it's interesting, right? It makes me think about whether the VCOM device or KPAP might be helpful here. But I guess the answer is we don't know.
Yes, we don't know. We can only speculate. We did talk to some startups with varieties of these kind of flexible pressures, higher pressure that talks lower. And this is a very interesting question, which we hope to test.
So if I'm understanding you right, there's maybe sort of an inflection point of 7, right? Above which we maybe have a little bit more risk. And of course, it varies by patient and body habitus and so on and so forth. Even though I know you have both separately said that this isn't enough to change, standard of care, has it impacted your practices?
Oh, I can volunteer here. Yes, ever since we found this, I have been prescribing lower pressures. Unless the patient is very obese, I prescribe 4 to 10, and if really heavy, then 4 to 12. And then I follow closely, generally try to do a 1-month follow-up. At the moment, I can get 31 days on a compliance report and see these patients. And I look at all numbers, and I especially look at the median pressure. And less important would be 95 or 90th percentile. So I really look at the median pressure. And I was struck by the fact that these median pressures, which are most commonly used and enough to reduce residual apnea-hypopnea index into normal limits or close, is really modest. As I said, 7, 8, maybe 9, but I would say 7 or 8 is something, this is completely anecdotal. If I see that a patient, and which is very rare, still has substantial residual apnea-hypopnea index, then we bring them in for titration. Or if the patient has a complex cardiopulmonary illness, of course, they come in for titration. But it did impact my care. And I have recently learned that in these autopups, once the patient requires high pressure of, say, 14 or so, it doesn't really instantly goes down. It takes about half an hour to be reduced down to lower levels. So it's really maybe a good idea to minimize the exposure to these rarely needed high pressure levels, I think.
I would concur with what Sanja just said. I think it's probably impacted her practice a little more than mine. But I have long, for the many patients who come in for evaluation because they snore, because they've been told they stop breathing, but who don't have any symptom complaints, I have for a long time not recommended CPAP for many of those patients because I think at this point what we know is that we can treat symptoms quite effectively, but we don't know that we're obtaining other benefits except in some very narrow situations, resistant hypertension, for instance. And so I think that I've probably prescribed less CPAP than most of our colleagues for quite some time. And I think that it's a lot of our patients don't like CPAP, especially the ones who are not very symptomatic. And I think that it may be that we're overprescribing a therapy based on a number that we get from a sleep study, and we need to really focus on the patient and not the AHI.
So what are you doing instead? A lot more mandibular advancement devices?
No, I think in patients who have asymptomatic sleep apnea, I recommend behavioral therapy.
You do.
positional therapy, weight loss, reducing alcohol, exercise.
Oh, sure. That's fair. Yep.
You know.
That's fair. Yep. Yep. I will say, Dr. Jelic and I started talking about this not quite a year ago, but around that time. And I think about it all the time. And I do kind of find myself doing lower and lower pressures. So I hear what you're saying, that this is not robust enough to change practice, but it was very impactful for me to hear that and to kind of look through your data. So yeah. So tell us, do you guys have a take-home message for us?
Well, from me, as in everything, moderation is a key. Moderate pressures.
Dan, how about you?
I think I largely gave mine. I think that I still believe that obstructive sleep apnea is a cause of increased cardiovascular risk. I think at this point, in all comers, it doesn't appear that CPAP reduces that risk. And that what will be important over the next few years is to understand whether other therapies may do a better job of reducing risk, or how we can identify the patients who are most likely to receive benefit versus harm from CPAP.
Well, thank you both for joining us today and helping us explore how higher PAP settings may cause more inflammation, and for helping us to understand how to incorporate your findings into our daily clinical practices.
Well, thank you for having us, Seema. It was a pleasure to be able to share this information.
Thank you, Seema, too. It was a pleasure.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.